Dear colleagues, ladies and gentlemen, welcome to the view from the Thoraxcenter for Radcliffe Cardiology. This time we preview the late-breaking trials for the upcoming TCT 2023 meeting. As always, my name is Nicolas from Mieghem and I'm doing this preview together with my good friend and colleague Joost Daemen. And Joost, there's a lot of structural data coming up.
Absolutely, as usual, a lot of focus on structure at TCT, and one of the key trials we wanted to present was the Partner 3 low-risk trial.
Yes, and this is immediately a two-piece trial, basically, because there will be a presentation by Marty Leon on the clinical outcome of Partner 3 low-risk at 5 years, and then there is back-to-back also a presentation by Becky Haan on the echocardiographic follow-up, and this is very relevant because we are talking about low-risk patients. This was the pivotal trial together with the EVOLUT low-risk randomized controlled trial. The mean age of the patient 73 years old, the STS score below 2%, and then the patients were randomized 1-to-1 to either the S3 or surgical aortic valve replacement. Mind you, in 2019, the original publication showed really favorable results for TAVI because TAVI outscored surgery in terms of 1 year composite outcome of mortality, stroke and rehospitalization. So it's going to be very interesting to learn what the situation is at 5 years. Is there a catch-up? Is this difference between TAVI and surgery maintained? We don't know. And then obviously we know from the Partner 2 that the previous generation of the balloon expandable valve, the SAPIEN XT, maybe in terms of structural valve degeneration was a little bit lagging behind surgery. But then the S3 registry showed that structural valve degeneration was basically in line of what you could expect from surgery. So this is for the first time a randomized comparison between S3 and surgery in terms of structural valve degeneration at 5 years. So that is very interesting data coming up. At the same time, when you say Partner 3, you also have to say the EVOLUT low risk. The EVOLUT low risk is the other pivotal randomized controlled study in patients at low operative risk. But this time patients are randomized to either TAVI with an EVOLUT system, the self-expanding supraannular functioning system, and in the control arm again surgery. Mean age of the patient 74 years old, again low risk patients, and this presentation by Mike Reardon will be on clinical follow-up at 4 years. So not at 5 years, at 4 years. And I don't think we will see any echo data out to 4 years. I think the echo follow-up will be at 5 years. So we zoom in on clinical follow-up, but we already know from the recent ESC meeting that out to 10 years, this supraannular platform is performing quite favorably as compared to surgery, because out to 10 years in the Notion trial, TAVI was outperforming, at least self-expanding supraannular TAVI platform was outperforming surgery in terms of structural valve degeneration. So the question is there a class effect in TAVI, or is this more device specific? Well, I think we will get the first answers to that question.
Absolutely, interesting. JenaValve.
Yeah, JenaValve is a totally different concept, right? All the designs of these TAVI platforms are specifically focusing on calcific degenerative aortic stenosis, and JenaValve is really introducing a different anchoring mechanism. So the leaflets, the native leaflets will be used for the anchoring of a new device. So it's a clipping mechanism, and that's why JenaValve is also focusing on pure aortic regurgitation without calcific disease, and this is very compelling. This is going to be, so the Align AR trial is the first prospective study that will look at the safety and feasibility of JenaValve at 1 year in patients with pure AR. We're talking about 180 patients, so quite a robust patient set for patients with aortic regurgitation. And the primary endpoint is valve performance, what are in terms of aortic regurgitation, but also hemodynamic mean gradients. And then also I'm interested in the neurological events and the need for new pacemakers, because it seems to be that patients with pure AR they have a higher risk for pacemakers. And so, because it's a different animal, it's not calcific aortic stenosis, so you will see more often dilated ventricles, there will be more tension on the conduction system, if you will. So that might translate into a higher pacemaker rate, but let's figure that one out in that presentation at TCT.
Yeah, I think it's important data, right? I mean, this is the first really robust, larger scale trial on the performance of the JenaValve. Yeah. So this will tell us a lot about this technology, which really is developed for patients with AR, which makes it a unique product. Yeah. And a device that we'll hopefully see more and more in the future.
And obviously the market of pure AR is much smaller than aortic stenosis, but at the same time this device also lends itself for treatment of aortic stenosis, so more to come on that.
Yeah.
There is also the VIVA trial. The VIVA trial is yet another trial by Rodas Cabau from Quebec, a randomized study comparing TAVI with surgery in patients with small anatomies. And this is relevant because, you know, there is an indication that TAVI may outperform surgery in terms of hemodynamic valve performance. So patients now are eligible if they have small anatomies, and a small anatomy is defined as a mean annular diameter less than 23 millimeters and a minimal diameter equal or less than 21.5 millimeters. So 300 patients will be randomized 1-to-1, and then the question that I have is, okay, what kind of surgery is recommended and is encouraged? Are we talking, will we see root enlargement, and will we see a high uptake by the surgeons to perform root enlargement? Because that would be a game changer, because if a surgeon would just implant small surgical bioprosthesis, then we know that TAVI will likely outperform surgery, because the TAVI devices that are being used in VIVA are either the SAPIEN valve, but also the supraannular functioning EVOLUT and Accurate platforms. So I think the main takeaway for me here will be the surgical arm. How effective will the surgeons be in implanting larger valves? And this is a very important discussion if you consider lifetime management and if you consider that the patient might outlive the bioprosthesis, because then obviously you are thinking in the future about a valve-in-valve procedure. And if you start with a patient prosthesis mismatch from the get-go, that's hard to correct with a TAVI procedure. So interesting from a concept point of view.
Definitely interesting, and also looking forward to see the screening log, to get a little bit more of a flavor on percentage of patients that were not enrolled simply because of a upfront preference for maybe a percutaneous strategy because of the small anatomy. Yeah,
and you expect obviously patients at lower operative risk, because otherwise why would you still randomize? Because in the high or inoperable patients there is no point in considering surgery.
Exactly, good.
All right, so let's switch now to the coronary space. A lot to do about drug-coating balloons. This is basically the theme of the last couple of interventional cardiology meetings, so also TCT 2023.
Absolutely. So again, a lot of hype on drug-coated balloons, and I think at TCT some interesting trials to highlight. Also acknowledged to be as one of the late breakers, and perhaps the most important one is the AGENT IDE trial. So AGENT IDE is the pivotal trial of Boston Scientific for their AGENT paclitaxel coated balloon. So as you know, DCBs are not available yet in the US, and this trial could be the first really dedicated IDE trial that could change that availability. So this trial is a randomized controlled superiority trial, randomizing approximately 500 patients to either the AGENT DCB or standard POBA for the treatment of in-stent restenosis and lesions between 2 to 5 and 4 millimeters of stents that were either BMS or a drug-eluting stent. So no selections for just BMS or DES restenosis. Any patient with in-stent restenosis can be enrolled. And with that, I think the trial is very interesting, because with this and the primary endpoint of target lesion failure at 1 year, you really dilute the exact added benefit of the paclitaxel on the balloon as compared to standard POBA. The trial is though very ambitiously powered, with a assumed event rate of almost 11% in the DCB arm versus 21% in the POBA arm. So with that, the investigators expect a 50% reduction in target lesion failure. I think it's a little bit ambitious, but that said, I think the trial is conceptually one of the most interesting trials I've seen to date, simply because you really dilute the effect of the drug on top of the balloon. This is not a comparison of a DCB versus a stent, which is conceptually obviously completely different, but in this case just the added benefit of the drug coating will be tested.
I think there's a lot at stake here. If this is a negative study, then we need to really question the...
On the program there are at least 3 or 4 deep dive sessions on this topic, so that typically suggests that there will be some data to digest afterwards.
There will be multiple perspectives for sure.
Yep. More on DCB is the DCB-ACS trial, which is a prospective multicenter randomized controlled trial from Harbin in China. So it's a trial comparing DCBs versus Drug-Eluting stents in patients presenting with ACS, so either STEMI or non-STEMI. Patients need to have a proper restoration of flow after standard POBA in a vessel with a reference diameter of 225 to 4 millimeters and a lesion length shorter than 28, which fits with the available length of the DCB. Primary endpoint is interesting, FFR at 9 months. With that, the trial conceptually follows the PAPA trial. I don't know if you recall that small trial from Amsterdam almost 10 years ago, in which our Dutch colleagues actually tried to assess the feasibility of a paclitaxel-coated balloon strategy in patients presenting with the ACS. They proved the feasibility, but also demonstrated a bailout stenting rate of 40%. And with that, I think I'm really curious to see this, what this trial will show us. I don't know what to think about it actually, because you would expect that with 40% bailout and a stent, in which the acute gain is much higher than with the balloon, that would affect the FFR at 9 months. That said, I could not find that many details on the trial details, sample size, etc. I don't know. I couldn't find it. So let's see what the Chinese investigators will tell us on this trial at TCT.
So as a principle, I'm a little bit worried because we're talking about an all-comer study in the context of ACS. But I'm still, in my mind, it's still okay. But ballooning, there is always a risk of recoil, and recoil is not being solved with a drug-coated balloon. So I think from a conceptual point of view, these trials, I'm wondering whether it's viable as a...
I agree. I'm very reluctant to believe that this will become a feasible, realistic strategy for patients with ACS and properly sized arteries. I'm not talking about a small 2 millimeter obtuse marginal branch. But there are 2 things. I think one, how this drug will dissolve in a ruptured plaque, to me is a little bit is a thing I find a little bit problematic to envisage, and the other item is that, again, as you say, I mean, this is a big vessel. The plaque has already ruptured, so the recoil concept might be different as compared to a fibrocalcific plaque in a big artery which is stable. So from that perspective, I do believe that some patients may have a sort of a benefit of ballooning alone, but with a lot of bailout rates, I don't know. We'll see. It's a lot to speculate, but let's await the results. Something completely different is TPAS, which is a large randomized controlled trial from Korea studying a abbreviated DAPT regimen in patients presenting with ACS. So again, STEMI and non-STEMI patients, 2,850 patients randomized 1-to-1 to either a abbreviated DAPT strategy of DAPT and then the interruption of aspirin at the time of discharge, after which Ticagrelor monotherapy will be pursued, versus a standard DAPT regimen of aspirin Ticagrelor for 1 year. 1 year endpoint, net clinical endpoint being any death, MI, stent thrombosis, stroke or major bleeding. So I expect, honestly, non-inferiority. This follows a little bit the results of the Global Leaders trial in which Patrick Royce and colleagues presented a sub-analysis also in ACS patients, in which they demonstrated no difference in the efficacy endpoints in terms of thromboembolic complications, but what they did show was a significantly lower risk of BARC 3 or 5 bleeding at 2 years in the patients in which aspirin was stopped early. So that could be so I think it's realistic that we'll see the same at least trend in TPAS. That said, this again is an Asian trial. Korean patients, which we know, and you've heard that from us already a lot of times, have a little bit of different ischemic bleeding profile as compared to Western populations.
Well, you know, it fits with this recent trend to trimming down the antithrombotic regime in the context of chronic but also acute coronary syndromes. I'm a believer in abbreviating the duration of DAPT, and I like the concept of continuing with aspirin out to discharge and then monotherapy from that moment on. But you know, there are some signals of an increase in definite or probable stent thrombosis in single antiplatelet therapy and early single antiplatelet therapy. So I'm going to be on the lookout for that. Is there a signal somewhere where we see an increase in early MIs or in definite or probable stent thrombosis?
Yep. Yeah. All right. So more on bleeding, but then switching gears a little bit.
Yeah, so we go back to the TAVI scene. There is an interesting randomized study in patients who undergo TAVI but have atrial fibrillation and an indication for oral anticoagulant therapy. In Watchtower, 349 patients will be randomized to either TAVI with a concomitant LAA occlusion with the Watchman device, and the control arm is TAVI with regular medical treatment. Samir Kapadia is going to present this study. I think from a trial design or concept, there are some questions because are these patients going to be blinded, yes or no? And if so, will all these procedures be under general anesthesia? So then you can basically blind the patient for the treatment arm. But if so, what kind of antithrombotic regime is associated with the respective therapy? So are patients in the Watchman arm, are they taking off oral anticoagulants? Are they continuing aspirin or clopidogrel, probably clopidogrel? Is there a follow-up echo to confirm whether you have a successful LAA closure? So multiple questions there in terms of trial design. At the same time, the primary endpoint is quite reasonable, and as expected is a composite of death, stroke and major or life-threatening bleedings at 1 year. So you hope that implanting a Watchman device will reduce the bleeding events. I think this is not a definite win. I'm a little bit.
I have no high expectations, honestly, but let's see.
Well, but you know, the other issue here is that patients are eligible if they can be treated with an LAA closure device according to the labeling of the device. But labeling in the US is different from labeling in Europe, and definitely different from labeling in the Netherlands. As a matter of fact, there is no reimbursement in the Netherlands for an LAA closure with a percutaneous device. So it's going to be interesting to see what kind of patients were enrolled in this study, and again, what was the screening rate, and were patients screened out because of anatomical variation, and so on. So there's more to that study than just the comparison of the two treatments.
Triluminate.
Yeah, so we now move to the tricuspid space. There are two interesting trials that we want to highlight on the treatment of patients with tricuspid regurgitation. The first is the Triluminate pivotal trial, already discussed, presented and published in the spring of this year. This was a randomized controlled study that was published in the New England, 350 patients with severe TR, and then randomized to tricuspid TR with a TriClip or a control. And you know, the results were somewhat underwhelming because people were expecting a home run in favor of TR, but that didn't turn out to be the case, although there was a more improvement in quality of life and a significant improvement of 12 points in favor of the TR arm, but there was no effect on 6-minute walk test, and also there were numerically more rehospitalizations in the TR arm. So that was definitely not a home run, so there was definitely a need for more data to support treatment of tricuspid regurgitation, and I think the next randomized trial is TriScent-2 that basically fills in a gap. This is a different trial. This is a trial that will enroll many more patients, but it has several sub-studies, if you will, embedded into that study. So there's a randomized controlled trial component, including 1,070 patients who will be randomized one-to-one to either control or transcatheter tricuspid valve replacement with the EVOLUT system. And high expectations there because as opposed to a treatment with TEER, with a tricuspid valve implant, the ambition is to really abolish the TR. Yeah. You want to get rid of the TR. So that might affect clinical outcome and might have a more comprehensive impact on clinical and functional status of patients. So that is the randomized controlled trial arm. But I think that they are not going to present the randomized or the full randomized controlled data, because if you look at clinicaltrials.gov, the trial will last until next year in the summertime. Yeah. So I think it's a bit early to get the full trial results, but there is a single arm study of patients who were turned down for the randomized trial. Those were in a nested registry, and there is another registry that continued access. So at the end of the study, the trial is the patients in the US can still benefit from treatment of TTVR, but then in a continued access arm. So what Sushil Kodale is going to present, I don't know. I tried to reach out to him, but he must have been too busy, so I don't know yet. But definitely something to look for, because we do need scientific data, randomized controlled data, to provide support for treatment of severe tricuspid regurgitation.
Yep. Good.
Okay, let's. There are some other concepts that also are being presented in terms of randomized controlled studies. One of them is the PICSO-AMI trial.
Yeah, so PICSO-AMI is a small randomized controlled trial under the leadership of our friend Adrian Benning. So as you know, PICSO, so for those of you who are not familiar with the concept, is pressure-controlled coronary sinus occlusion, which is a technology developed by Miracor, which was designed actually to decrease infarct size following acute myocardial infarction. The feasibility of the concept was recently tested in some relatively small studies, but this is an important one because this is the first randomized controlled trial enrolling 144 STEMI patients with large anterior myocardial infarctions. So the patients really need to have proximal or mid-LAD occlusions. After which they will be randomized to either standard of care or standard of care plus the PICSO treatment algorithm. Small registry arm will also be added to the trial of around 30, if I'm correct, non-STEMI cases, just to test the feasibility of the concept. Primary endpoint, MRI-based infarct size, as you would expect, at 5 days. And with that, I think this is a trial to look out for. There's, by now, I think, a large pipeline of PICSO-AMI 1, 2, 3, I think even 4 has been announced. On the website of Miracor, you find 33% infarct size reduction based on the data they have. But if you look into the details, this is based on 14, 22 patients, propensity matched. So with that, I think this trial is going to be very, very important for the company, but even more for us as physicians, to see if this technology is going to really make it's really going to be a game changer in terms of treating large anterior MIs.
You know, the concept is trying to survive, right? And I think this trial with 144 patients with an MRI infarct size endpoint, this is a lead out to other more robust trials that should be coming in the future. But let's first see what the data will be from this study. And then obviously an interventional cardiology meeting cannot end without a study on renal denervation, Joost. So what do we have here?
Yes, that's correct. So also here this year at TCT, some interesting RDN data to be expected. One is or maybe the most important one is the 6-month pooled data of the Radiance trial program that will be presented by the study PI Michel Azizi. So please recall the Radiance program encompasses 3 randomized sham-controlled trials. Now 506 patients that were randomized to either ultrasound-based RDN or sham for the treatment of mild to moderate hypertension in Radiance Solo and Radiance 2, or patients with therapy-resistant hypertension on a standardized triple pill combination in Radiance Trio. Recall, all these 3 trials met their primary endpoint at 2 years in terms of efficacy, showing a significantly larger blood pressure reduction following ultrasound RDN as compared to sham. But as you know, these patients were followed for 6 and 12 months, in which a stepwise antihypertensive drug regimen was applied in those who were not on target. Physicians at this stage, and that's important to realize, were blinded to the treatment allocation. And with all the discussions about the durability of the treatment, the safety of the treatment and the longer term, I do believe these data are important because they will tell us a little bit more about the durability of the treatment, the difference of the ultrasound-based RDN effect on top of drugs, and also in terms of the safety, at least up to 6 months in this largest ultrasound RDN trial program thus far.
But will we see any new data, like extended follow-up? Is there anything?
6-month data is new, at least for Radiance 2. Yes.
For Radiance 2.
Yeah.
Oh, okay. But it's not that we will have like 3, 4, 5-year outcome data for the entire cohort.
Not for this entire cohort, because Radiance 2 obviously is now at 1 year, and that is something that is ongoing.
Okay, so it's more an integrated perspective on the existing data.
Absolutely.
All right. Thank you very much, Joost. Anything else that we want to discuss?
No, that's it. Thank you for watching.
Will you be in San Francisco?
I will be in San Francisco.
Me too. So with that, we will see you there, and we'll come with a wrap-up after TCT. Stay well.